Ladies and gentlemen, we go now to the next lecture, neonatal conjunctivitis. Still low. People attending. Okay. These are the causes of neonatal conjunctivitis. But before we go to the causes, maybe it's important to appreciate what is a neonate. What is a neonate? Any idea? I think it's the first 3 months. No idea. Causes of neonatal conjunctivitis: chlamydia organisms, gonococcal. And where does the child get gonococcal, these gonococcal organisms? An idea? Everyone is scared to answer, is it?
Maybe it's a network.
Yeah, maybe. Chlamydia and gonococcal chemicals.
Carry on. Carry on.
Oh. Chemicals, simplex, simple bacterial conjunctivitis. Gonococcal and this chlamydia usually through the birth canal of the mother as the child is being born. You find in the first maybe few weeks, they've got, in fact, days, they get this conjunctivitis. They've got it as they were coming out of the mother's womb. Chlamydial conjunctivitis, most common cause of neonatal conjunctivitis. Clinical features: presents between 5 and 14 days after birth with acute conjunctivitis, which is mucopurulent in nature with a lot of pus oozing out from the eyes. The conjunctiva papillary reaction also occurs. It's quite a severe, conjunctivitis, and it needs to be sorted out urgently. Otherwise, you can have perforation of the cornea and the child will be in problems with the vision. Topical tetracycline ointment, oral erythromycin. Then you have to check both parents for evidence of genital infections. I think in terms of treatment, I want you to take note. In terms of treatment, this is a child who has got a lot of pus in the eyes. You don't go in straight to put tetracycline. You have to wash out the excess pus. Otherwise, you putting the tetracycline without doing anything, you're actually plugging the organisms behind the ointment. So the eyes must be, the eyelids, you open them, irrigate, it will clear the pus. After you've cleared the pus, that's when you put in this tetracycline ointment. If you don't do that, what you are going to be doing is plugging the organisms around the cornea. You put the ointment, but it's just plugged. And that's the easiest way of ultimately ending up with a perforated cornea. You don't want to end up that. So you must retract the eyelids, wash before you put in the tetracycline. If you don't do that, you're plugging the pus behind. Please, 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 please take note. Checking both parents for evidence of infections. These are swabs. Whether people are living, you can check that. But sometimes you find these parents, even before you are talking of checking by the parents, they know about it, and each one is blaming the other as the cause. Besides, you won't know who started it, because since these two people, the parents you are checking, they are partners, they probably both have the same organisms, because they've been sleeping together. So who brought this in the family becomes now a very difficult issue. And the other parents may not agree. No, it's my wife. Gonococcal conjunctivitis transmitted from mother to child during the delivery of the child. It's caused by Neisseria gonorrhea. These are the organisms, the name of the organism, the Neisseria gonorrhea. Clinical features. This slide here. Why is this there?
Just click there.
Presents between the first and third days after birth with conjunctivitis, which is very hyperacute, severe conjunctivitis, a lot of pus, purulent pus, and swollen eyelids. Membranes and pseudomembranes may be present. Keratitis and even gonorrhea, cornea perforation may occur in late cases. So this is a very serious issue. There's nothing like tomorrow. It's better you sort it out there and then. Especially opening up the eyelids and washing. Then use the tetracycline, or you can use eye drops. I prefer myself to use eye drops like gentamicin. Eye drops, they have that effect like they're washing away the excess pus. The tetracycline is oil, it plugs. Myself, I go through for gentamicin is better to me. These are some of the pictures. You can see severely inflamed conjunctiva on the sclera, inflamed on the eyelid. All this is pus there, this whitish stuff there. Treatment, admit the patient if the following conditions prevail. Cornea involvement exists or cannot be excluded because of chemosis. Chemosis, swelling of the eyelids. Okay. Irrigate the eyes with saline or clean water before each application of antibiotic drops. I think this is the most important issue to look at. You don't just start going in, open the eyelids, irrigate to remove the excess pus, then put antibiotics. I use eye drops myself. I prefer gentamicin myself. And it's quite good. Then you can add on that the injectable ones like freetraxone, 1 gram IM, single dose if cornea is involved. Ciprofloxacin eye drops can be used. Doxycycline twice a day for 7 days. Treat sexual partners with oral antibiotics. Who are the sexual partners? Usually the parents. Must be only treatment with oral antibiotics. Follow up daily until improvement is noted. Then every 2 to 3 days until condition resolves. This has been put there as a precaution for the child. This is not a patient you start treatment and send home. At least for 2-3 days, they must be in the hospital if you can afford. So that you see them every day. Morning, you go there in the morning, lunch hour, see the progress. Once you send such patients home, they will come back with perforated cornea. They will come back blind. These are patients I prefer to admit. At least for 2-3 days, you have that intensive treatment. In the morning, you open the iris, clear away the excess pus, put in the eye in antibiotic eye drops. Lunch hour or 3-4 times like that during the day. You find by the end of the second day, the child is able to open the eyes on its own and start seeing. The idea of giving them treatment at kunganda muye mukubikako, most of the parents are very careless. They just go and pack. After 3 days, but the child is already blind. What next? They've lost everything. The other conjunctivitis is allergic conjunctivitis, what we call seasonal allergic conjunctivitis. It's an acute allergic conjunctivitis. Vernal keratoconjunctivitis. I'm sure you've heard of vernal. We talked about vernal some time back. Or atopic keratoconjunctivitis. Allergies to drugs can also occur. But this keratoconjunctivitis or atopic keratoconjunctivitis, these usually is from pollen with a seasonal. Flower pollen, you find some people, some children, even adults, you find they are watering. It's normally watering and pigmentation, brown pigmentation of the eyes. Vernal keratoconjunctivitis. And it's seasonal. Once the season changes, they look quite okay. The worst season is after harvest, March to April, May, like that. I think we discussed this one, isn't it? Previous allergic conjunctivitis. Seasonal allergic conjunctivitis, hay fever, common allergic reaction caused by airborne antigens, spores, weeds, weathers, pollen, grass, wool. This, in terms of farmers, usually after harvest, April, May, somewhere there with a lot of wind, they get this. And this is a type 2 hypersensitivity response mediated IgE antibodies bound on membrane of the mast cells in the conjunctiva and substantia propria. Binding of antigen to antibody causes degranulation of the mast cells, leading to release of inflammatory mediators, which are histamine and leukotrienes. These are the ones now which cause the irritation. You find a person who have just watering eyes, brownish in color. Something that has been, it's not a one-day affair. It's every day, every season it gets like that. Clinical features, presentation, acute transient attacks of itching. Very, very common. And the itching, people will be forced to, like they want to scratch. You can scratch with your nails in the eye, but they will use the back and they will be, what you call, ukufikinya. You know that, Bemba?
Yes.
Yes. Ukufikinya menzo. So the eyes will be watering. When you are ulefikinya menzo, one hopes that the hand you are using to do that is clean. But for children, you can't guarantee that. They are playing in the soil. Straight.
There's a question.
Yes, what's the question, man?
What type of antibiotics do you use to treat the parents of the infected child?
I would prefer if you can take a sample. But a broad spectrum antibiotic like gentamicin is not bad, injectable. Ciprofloxacin is not bad. But where, if you can get cooperation of the patient, a sample wouldn't be a bad idea. You know, from the pus which is being produced. Then when you get the sample, you take it to the lab. You don't wait for the lab to give you the sample. You can put them on a broad spectrum antibiotic while you are waiting for that sample to come back, the results. The results come back, you can modify in the next 24 hours. I think that is the practice. Where there is an acute condition, you take the sample, take to the lab. You don't wait at mpaka sample ikawere, that's when you start treatment. You start treatment based on your clinical judgment, and following there, you can change. You can change. If you think the drug you put the patient on is not working. The worst you would do is to send the sample and start telling the patient, to sample treatment. You don't do things like that. Yes, sample can go, start treatment based on your clinical judgment. Next 24 hours, a result will come. And you can change if you want to change or continue with the same. But never wait. It means you are giving the bacteria another 24 hours to enjoy themselves. What else? Question? Did I answer the question? Or is still there?
I don't know if she's satisfied.
I did? The child, I personally use eye drops, gentamicin eye drops, ciprofloxacin, like that. Eye drops. This you treat with eye drops. What's the other question? What type of antibiotics? Antibiotic eye drops, gentamicin, ciprofloxacin, like that. It's better.
She was asking about the parents of the infected child.
The parents of the infected child, I would still use ciprofloxacin oral, ciprofloxacin oral or gentamicin injection. I would use that. Those are strong sort of broad spectrum antibiotics. And you have the opportunity to review that treatment because you have maybe taken a sample. You will see by 24 hours whether they are catching up, they're getting better or not, and you can change. You probably also have tested in the lab for sensitivity for the organism. They will tell you the organisms are sensitive to this and this. Then you can continue or change. Clinical features, you have this. This is not the disease. The disease is the allergy, isn't it? Where is it? Seasonal allergy. Because it has just appeared suddenly. So allergic conjunctivitis. On examination, you have mild conjunctiva chemosis, edema, and diffuse papillary reaction. Treatment, eliminate the inciting agent where possible. Find out what is the cause. In some cases, you get it. In some cases, it's very difficult, especially in rural areas. People are exposed to a lot of things. Those that go into gardens, it's a natural. Every adult has to go out to the field to cultivate, isn't it? Otherwise, they will end up starving. You can use cool compresses or topical medications in severe cases, artificial tears, oral antihistamines. Antihistamine is anti-allergic, okay? Or mast cell stabilizers like sodium chromoglycate drops. If you can't get any of these, steroid drops can help, as long as there is no evidence of bacterial infection in the eyes, like pus is also pouring out. Because these things usually will start as an allergic conjunctivitis. The child is busy poking, catarrh kufwenya. That's also introducing the actual bacteria now on top of the allergic type. So if there is evidence of any pus, first sort out the pus with an antibiotic. First with that. If there is no pus, there is just watering of eyes coming out. It's like clear-cut allergic conjunctivitis. Those you can do sodium chromoglycate, or you can do steroid eye drops. Okay. Vernal keratoconjunctivitis, what is called spring catarrh during spring. Common recurrent bilateral ocular inflammation affecting children and young adults. Even adults, old adults, not only young adults. Even old adults can be affected. Common in males than females. Allergy is an IgE-mediated reaction. 3/4 of the patients have associated atopy. They are generally allergic people. And it's a common condition, this. There you are. Initially, diffuse superior tarsal papillary hypertrophy with this, when you check there. Oh, no.
Carry on. It's okay.
Then this one, you can see when you turn, like it's, what do you call this? Giant cobblestones, like stones put together. Clear cut when you check. And this patient will have this when you check, but they will have watering eyes. And depending on the age of the patient, you'll find the watering eyes and also evidence of bacterial infection, because they've been trying to scratch. What was ukufikinya? The members go into ukufikinya. Two-thirds of the patients have a close family history of atopy within the family. Asthma, eczema is common in atopic patients. And onset is usually at the age of 5 years and resolves by the age of 25. By the time this young man is considering to marry at 25, the allergy is gone, thank God. He can't be chased by a lady. Clinical features, symptoms, intense ocular itching. And for children, they will try to scratch even with dirty hands. So from the itching, the patient himself introduces the bacteria into the eyes. And you may have now a combination of bacterial infection and allergy, two features. Sort out the bacteria, put the patient on antibiotic, a combination of antibiotic and allergic and anti-allergic. They will sort out, they will be okay. Symptoms, intense ocular itching. No one leaves the eyes alone once they are itching. They always want wanting to scratch. Lacrimation, watering eyes, photophobia, foreign body sensation, burning sensation, and symptoms may occur throughout the year. Palpebral vernal keratoconjunctivitis, palpebral VKC, initial conjunctival hyperemia, chemosis. Chemosis is edematous, yes, diffuse papillary hypertrophy, most marked on the spirotarsals. You saw the picture with the time. Papilla then become larger and have flat tops. That's what they refer to as cobblestones. It's a stage further of the condition. Redness and swelling characterize active disease. So these are the features. You will see a lot of this stuff in the usually in Zambia, everywhere. That's the next one. Vernal keratoconjunctivitis, this is just around the limbus. The limbus transition from sclera into the cornea. Yes, that's the limbus. You have punctate epitheliopathy, and is an early feature and involves upper cornea, involves the upper cornea. Microerosions later form up. Okay. These are the limbomucoid nodules. This will be brownish, you know. This will be brownish. This is somehow clear. If you evade the upper lid, you find there may even be cobblestones. Limbitis, this characterized by limbomucoid nodules with discrete white superficial spots. These are also called as Tarantus dots. Okay. Yep. Any questions, ladies and gentlemen? These conditions are very common here in Lusaka, in Zambia. You will see a lot of them. In the clinic, you will see a lot of them once you start going into the clinic. Any questions, ladies and gentlemen? Oh, 4 minutes remaining. Good.
I don't know if they're saying anything.
Hmm?
I don't know if they're saying anything.
If they are saying anything.
If they'll have a word.
I want to hear if they were any questions or they are happy. Full stop. They should be happy. You record this, isn't it? You've been recording it? Okay. Everyone should be happy. This is a very common condition. In the clinic, you will see it every day.